Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine opening an abdomen in the operating room, expecting a straightforward resection. And instead, you find what looks like concrete poured over the patient's internal organs.
Yeah, it's a completely daunting visual.
Right. I mean, the stomach, the small bowel, the spleen, they're all just fused together by this diffuse, unyielding layer of disease.
And for decades, right, surgeons would take one look at that and they'd just close the patient back up.
Exactly. You'd close them up and deliver a terminal prognosis. Maybe, 6 to 12 months if systemic therapy bought them some time. But today we're talking about the surgical teams who refuse to close.
It really is a profound shift in surgical philosophy. We went from viewing peritoneal metastasis as an absolute contraindication for surgery, like just a complete systemic failure, to approaching it with this really aggressive curative intent.
Because the biological understanding of the disease finally caught up to the surgical ambition. Welcome to this deep dive. Today, we are speaking directly to you, the surgeons, the oncologists, and, the medical professionals tuning in.
We're taking a very comprehensive clinical look at the surgical management and the biology of peritoneal metastasis.
But before we get too deep into the weeds here, I do need to state our mandatory disclaimer. This content is for reference only. Always follow your local guidelines in clinical practice.
So our goal today is to really unpack the mechanics of that evolution. We're looking at, why the surgical playbook completely changed, the physiological mechanisms driving these massive interventions, and the molecular horizon that might just change everything all over again.
Okay, let's unpack this. Historically, the moment cancer hit the peritoneum, it was game over. The sources we're looking at today, which are this stack of contemporary clinical reviews, they point out that this specific type of spread operates on a completely different mechanical level than other metastases.
Right, mostly arising from, gastrointestinal and gynecological primaries.
Yeah, like colorectal, gastric, ovarian, and appendiceal.
Exactly. And the mechanism of dissemination is the key differentiator here. When we think of typical metastasis, we usually visualize hematogenous or nodal spread, right?
Through blood or lymphatics.
Yeah, tumor cells intravasate into the bloodstream or the lymph nodes. They travel to a distant capillary bed, say, in the liver or the lungs, and they form these discrete solid nodules.
But peritoneal metastasis doesn't do that.
No, it relies on exfoliation. The primary tumor penetrates the serosa, and viable cancer cells just shed directly into the peritoneal cavity.
They just break off and float away.
They break off, and crucially, they manage to survive in the peritoneal fluid. Once they're suspended, they just travel along the natural intra-abdominal circulation currents.
Driven by gravity and the negative pressure from the diaphragm moving, right?
That's it, exactly.
The papers describe them implanting in dependent areas. So we are talking about the pelvis, the pericolic gutters, and the subphrenic spaces. And as I was reading this, the image that kept coming to mind, it wasn't, a single weed with a deep root growing in a garden. It was more like blowing a dandelion head across a wet lawn.
That is a great analogy.
Because the seeds just scatter, right, and they stick and grow wherever the water naturally pools. You don't get one distinct mass. You get this diffuse coating all over the serosal surfaces.
And clinically, that diffuse, that wet lawn is what we define as carcinomatosis. And it fundamentally alters the pharmacokinetic reality of treating the disease.
How so?
Well, you are no longer dealing with a well-vascularized tumor mass. You're dealing with multifocal nodules, microscopic plaques, and sometimes completely confluent sheets of tumor.
Just replacing the natural tissue.
Replacing the natural mesothelium of the omentum and parietal peritoneum entirely, yeah.
Which explains why systemic chemotherapy historically falls so flat here. Because if you have a massive surface area of these dandelion seeds, but they aren't deeply tied into the body's vascular network.
The intravenous cytotoxic drugs circulating in the bloodstream simply cannot reach them.
Right. The systemic therapy is literally locked out of the target zone by a lack of blood supply.
The blood-peritoneum barrier is incredibly effective at keeping large molecular weight chemotherapy drugs out of the cavity. The systemic drugs might manage to penetrate the outermost millimeter of peritoneal nodule, maybe.
But the core is untouched.
The core of the plaque remains completely unexposed and viable.
Which brings us to the brutal art of cytoreductive surgery, or CRS. Because, if systemic chemo physically cannot penetrate the dandelion seeds, surgeons had to figure out a way to physically remove the entire lawn.
If pharmacology fails, Mechanical eradication becomes the literal only option. The primary objective of CRS is absolute. It is the complete extirpation of all macroscopic, visible peritoneal disease.
Meaning everything you can see has to go.
Everything. Anything less basically defeats the purpose of opening the abdomen.
But the scale of these procedures is staggering. The literature details peritonectomy procedures combined with massive multivisceral resections.
Oh, it's immense.
We're talking omentectomy, stripping the diaphragmatic peritoneum, stripping the pelvic lining, multiple segmental bowel resections. It's essentially remodeling the entire abdominal cavity.
And to quantify that tumor burden, to determine if that remodeling is even physically possible, surgeons utilize the Peritoneal Cancer Index, the PCI.
Right. That divides the abdominopelvic cavity into 13 regions.
Correct. The size and distribution of the lesions in those 13 regions generate a score, which serves as this really critical preoperative and intraoperative predictor of resectability.
And the success of that resection is graded by the CC score, right?
Yeah.
The completeness of cytoreduction.
Yes, the CC score.
The sources stress that a CC0 or CC1 score, meaning no visible residual disease, or at most nodules less than 2.5 millimeters, is an absolute requirement to gain any survival benefit.
The survival data just drops off a cliff if you leave anything larger behind. It is a strict biological threshold.
So if you leave bigger pieces,
a CC2 or CC3 resection means the patient absorbs all the trauma of a 12-hour surgery with practically zero oncological gain. It's devastating.
But wait, this is where I really struggle with the mechanical reality of the surgery. I'm reading these operative descriptions, and they talk about the omentum turning into a solid, quote, tumor cake.
Yeah, that's the clinical reality of it.
They describe the pelvis being densely scarred down and tissue planes, the natural avascular anatomical boundaries that surgeons rely on to separate organs safely, just being totally obliterated.
Entirely.
Yeah. So if the planes are fused with tumor, how on earth does a surgeon aggressively resect all of this without just blindly hacking into vital structures? Or worse, taking so much intestine, they leave the patient with short-bowel syndrome.
What's fascinating here is the sheer technical tightrope the surgical oncologist has to walk, and it perfectly explains the notoriously steep learning curve of this specialty.
Because it's not a standard resection.
Not at all. When those tissue planes are obliterated by the tumor cake, standard blunt dissection is impossible. You can't just push the tissues apart with a swab or your finger.
Wow.
The surgeon is forced into sharp, millimeter by millimeter dissection. They're often using electroevaporation to strip the diseased peritoneum off the underlying muscle or organ capsule.
And what if the tumor has invaded the organ capsule itself?
Then the organ has to go. It is standard for a comprehensive CRS to involve a partial gastrectomy, a colectomy, a splenectomy, a hysterectomy, and a cholecystectomy in a single operation.
All at once?
All at once. The imperative is oncological clearance. But, as you pointed out, the small bowel is the absolute limiting factor.
Right, because you need it to live.
You can live a relatively normal life without a spleen or a colon. You cannot live a meaningful life without adequate small bowel length to absorb fluid and nutrients.
Over-resection leaves the patient dependent on TPN total parenteral nutrition for the rest of their life, which carries massive infection and hepatic risks of its own.
The calculus is really unforgiving. If achieving a CCU resection requires resecting so much small bowel that the patient will be left with short bowel syndrome, the operation is often aborted right there.
You just stop.
You have to. The morbidity of the cure cannot exceed the morbidity of the disease.
Speaking of morbidity, let's talk about the physiological toll, because it forces a really hard look at whether these added interventions are always justified. We are looking at major complication rates in the daunting 20 to 40% range for CRS.
The trauma to the human body is immense. When you strip the subdiaphragmatic peritoneum, you are physically traumatizing the diaphragm muscle.
And disrupting lymphatic drainage.
Exactly, which invariably leads to significant respiratory complications and pleural effusions. Plus, you have a high risk of anastomotic leaks.
Because you're joining bowel segments in a highly catabolic, stressed patient.
Yeah, their body is in overdrive. And then there is this systemic inflammatory response to an operation of that magnitude.
And that's just from the cold steel of the surgery itself. Because then comes the HIPEC, the heated intraperitoneal chemotherapy.
That's the next phase.
You've just performed this massive multi-organ resection. The patient is wide open or temporarily closed, and you bathe the entire abdominal cavity in a chemotherapy solution heated to around 42 degrees Celsius for up to 90 minutes.
The rationale behind the heat is synergy. Hyperthermia alters the lipid bilayer of the remaining microscopic cancer cells.
It makes them more vulnerable.
It makes their membranes more permeable, yes. It also impairs the cell's ability to repair DNA damage. So by combining heat with a cytotoxic agent like mitomycin C or oxaliplatin, you increase the penetration depth of the drug.
Into that residual microscopic tissue.
Exactly. You push it from perhaps 1 millimeter down to 3 millimeters.
But the metabolic stress of that, I mean, you're essentially inducing artificial systemic hyperthermia on a patient who has just undergone a massive trauma.
The anesthesiology team is fighting a massive battle during the HIPEC phase. The patient's core temperature rises, creating a hyperdynamic state.
Their heart rate goes up.
Their peripheral blood vessels massively dilate to dump the heat, which tanks the blood pressure.
Oh, wow.
Yeah, this causes profound fluid shifts that have to be aggressively chased with IV fluids and vasopressors, all while managing the risk of coagulopathies.
Here's where it gets really interesting. With the complication profile that severe, you'd assume the survival benefit of adding the heat is undisputed.
You would think so.
But one of the papers highlighted the Prodigy 7 trial, which essentially threw a grenade into the medical consensus.
It absolutely did.
This major trial questioned if HIPEC actually adds a survival benefit for colorectal peritoneal metastasis over just doing the CRS and relying on modern systemic therapy.
Prodigy 7 was a massive inflection point for the surgical oncology community.
Yeah.
Because for years, CRS and HIPEC were treated as an inseparable package.
You couldn't have one without the other.
Right. But the trial demonstrated that for colorectal primary specifically, adding HIPEC to the cytoreductive surgery did not significantly improve overall survival.
But it did increase complications, didn't it?
It did measurably increase late postoperative complications, yeah.
So the modern systemic chemotherapy for colorectal cancer has gotten so good that the physical scalpel is enough and the heated chemical bath is just unnecessary trauma.
For colorectal PM, that is exactly the shift in thinking. Regimens like FOFOX or FOLFI combined with targeted biologics are highly effective.
So the heat doesn't add much.
If the surgeon achieves a true CC0 resection with the scalpel, exposing the patient to the hyperthermic toxicity of HIPEC doesn't seem to offer an additive survival advantage. However, and this is a big however, the primary tumor's biology dictates everything.
Right, because the sources stress that this isn't a one-size-fits-all disease.
Far from it. If a patient presents with favorable histology, such as a low-grade appendiceal mucinous neoplasm leading to pseudomyxoma peritone, or, say, certain advanced ovarian cancers, the combination of CRS and HIPEC remains the absolute gold standard.
They respond better to it.
Those specific tumors are highly sensitive to the heated intraperitoneal drugs, and the survival curves reflect undeniable long-term gains.
And then on the far other end of the biological spectrum, you have gastric peritoneal metastasis. The literature notes that gastric cancer biology is so inherently aggressive and poorly differentiated that despite our best efforts with aggressive CRS and intraperitoneal chemo, the outcomes remain incredibly poor.
If we connect this to the bigger picture, it all comes back to patient selection. It is the defining variable of success.
You have to pick the right battles.
Precisely. A high PCI score, extensive involvement of the small bowel serosa, or a poorly differentiated tumor biology easily tip the scales against surgery. Performing a 12-hour cytoreduction on highly diffuse, aggressive disease isn't heroic, it's futile.
But what happens when that PCI score comes back at a 28? When the tumor kick is so extensive that even sacrificing the bowel won't give you clear oncological margins?
It's a devastating situation.
You can't just close the patient up and do nothing because the symptoms of end-stage PM are agonizing. So how does the surgical mission change?
The mission pivots entirely from oncological clearance to symptom management and quality of life. The surgeon's role in the palliative setting is arguably more complex, requiring an immense judgment.
Because they're so frail.
You are navigating how to provide relief to a highly fragile cachectic patient without putting them through an operation they will never recover from.
The sources outline the horrors of malignant bowel obstruction. Patients can't eat, they are constantly vomiting, and the pain is severe.
In those scenarios, surgeons might perform limited palliative procedures, creating a stoma upstream of the obstruction, forming a surgical bypass around the blocked segment, or doing a very limited resection just to restore continuity of the GI tract.
The goal is simply to allow the patient to return home and eat a basic diet.
That's the only goal, quality of life.
The management of malignant ascites also sounds incredibly challenging. This rapid, massive accumulation of fluid in the abdomen caused by the leaky tumor vasculature. The sources note it responds terribly to systemic therapy.
Because, again, The systemic drugs can't penetrate the peritoneal cavity to stop the fluid production at the source. Patients become massively distended, compressing their diaphragm and making it hard to breathe.
And they need drainage, right?
They end up requiring repeated paracentesis large volume needle drainage every few weeks. But that constantly depletes their serum proteins, leading to further physical decline and introducing severe infection risks.
It's exhausting just reading about the physical toll, which highlights exactly why this entire field requires dedicated, high-volume, multidisciplinary centers.
You absolutely need a specialized team.
You need surgical oncologists, medical oncologists, specialized radiologists to even read the subtle peritoneal disease on a CT scan, and a robust palliative care team.
The learning curve isn't just for the surgeon's hands. It's for the entire institution's critical care infrastructure.
But the research doesn't stop at the current limitations. The sources gave us a glimpse into the future directions of treatment, focusing heavily on getting drugs into the cavity without the massive morbidity of HIPEC. They detailed HIPEC pressurized intraperitoneal aerosol chemotherapy.
HIPEC is a brilliant mechanical solution to a pharmacological problem.
How does it work?
Instead of pouring a large volume of liquid chemotherapy into the abdomen and hoping it circulates into every crevice, surgeons use a standard laparoscopic setup to spray the chemotherapy into the inflated abdomen as a pressurized aerosol.
The analogy that immediately jumped to mind for this was painting a complex 3D object. If you try to just dip a complicated object into a bucket of paint, the liquid struggles to get into the tight corners because of air pockets and surface tension.
Exactly.
But if you use a can of spray paint, that pressurized aerosol effortlessly coats every single microscopic crevice evenly.
That is precisely the physics at play. The capnoperitoneum, the gas used to inflate the abdomen for the laparoscope, creates a high-pressure environment.
And the pressure forces it in.
That pressure gradient literally forces the aerosolized chemotherapy particles deeper into the interstitial space of the tumor nodules. You achieve significantly better tissue penetration using a fraction of the standard chemotherapy dose.
Which means less systemic toxicity for the patient.
Exactly. It allows for repeated, minimally invasive treatments that can effectively control malignant ascites and shrink the peritoneal nodules.
Oh, wow.
Sometimes even downstaging a patient who was previously unresectable into a candidate for full CRS.
That's incredible. The papers also mention the push toward normothermic intraperitoneal chemotherapy, basically ditching the heat entirely to save the patient from the immense thermal and metabolic stress, relying purely on better drug delivery systems.
Yeah, that's gaining a lot of traction.
And then there's the ultimate holy grail, precision molecular medicine.
We are finally looking beyond the scalpel. Researchers are targeting the actual molecular pathways that allow this disease to function. If we know that peritoneal metastasis relies on exfoliation and attachment.
The dandelion seed sticking.
Right. We can target the specific cell adhesion molecules, like integrins and CD44 receptors, that act as the molecular glue, allowing those cancer cells to stick to the mesothelium in the first place.
We are looking at stopping mesothelial apoptosis, essentially preventing the tumor cells from degrading the natural peritoneal barrier.
The clinical trials are evaluating agents that physically dismantle the tumor microenvironment. But for the practicing surgical oncologist today, right now, the ultimate challenge remains one of profound clinical judgment.
Figuring out the right approach.
Knowing exactly when peritoneal disease is controllable by major cytoreductive surgery, and possessing the restraint to know when the goal must be limited to symptom-focused palliation.
So what does this all mean? We've traced an incredible journey today. We've seen peritoneal metastasis evolve from an untouchable systemic death sentence into a localized disease that can be aggressively managed by tailored surgical and chemical interventions.
It really is a completely new era.
We've explored the sheer physical challenge of the tumor cake, the razor's edge between oncological clearance and short-bowel syndrome, and the fierce debate over the true value of hyperthermic chemotherapy in the modern era. And through it all, understanding the unique biology of the primary tumor remains the ultimate key to patient survival.
And I'd like to leave you with a final provocative thought based on where that molecular science is heading.
Yeah, let's hear it.
As we gain a deeper understanding of the genetic and molecular pathways of peritoneal metastasis, the matrix degradation, the mechanisms of cell adhesion, the evasion of anoikes, will we eventually develop targeted agents that supplant these massive 12-hour cytoreductive surgeries entirely?
That would be amazing.
Will the scalpel one day be completely replaced by the targeted metabolic dismantling of the tumor cake?
It's an amazing thought, changing the biochemistry of the soil so the dandelion seeds can't even sprout rather than having to rip up the entire lawn. If you liked this content and found it valuable for your clinical understanding, please do not forget to share this deep dive with at least one of your colleagues or friends to help spread the word. The more we discuss these specific advancements, the faster the field moves forward.
We deeply appreciate you taking the time to explore the clinical realities of this disease with us.
Be sure to check out our YouTube and other social media pages for more content. And definitely check out our previous season and deep dives. We have some very relevant topics covering other groundbreaking medical and surgical advancements that you absolutely won't want to miss.
There's always more to learn in this field.
Because at the end of the day, the diagnostic imaging for peritoneal metastasis may always be a bit murky, but the science cutting through that fog has never been sharper. Thanks for listening.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.